to highlight the differences between the terms enlargement and hypertrophy. Usually, enlargement refers to increased chamber size, whereas hypertrophy refers to an increased chamber wall thickness. Although it is sometimes suggested that enlargement is from volume overload and hypertrophy is from pressure overload, this dichotomy is overly simplistic and should be avoided. Unfortunately, the EKG is poor at distinguishing enlargement from hypertrophy, which generally requires cardiac imaging such as echocardiography or MR. The first step to understanding the EKG changes from atrial enlargement. Here is a picture of a typical P wave as it might appear in lead 2. The area under the curve, that is the area bounded by the waveform, roughly represents the relative mass of the atria. Since the sinus node is in the RA, RA is depolarized first and the LA second, and thus the first portion of the P wave is from right atrial depolarization and the second portion is from left atrial depolarization. Therefore, in the most general sense, right atrial enlargement affects the first half of the P wave, and left atrial enlargement affects the second half. In right atrial enlargement, the increased mass leads to greater voltage and a greater duration of time over which the depolarization occurs. Here is left atrial depolarization unchanged. You can see that there is substantial overlap now of the timing of the depolarization of these two chambers. As a consequence, the P wave in right atrial enlargement tends to be unusually tall. The specific cutoff that most clinicians use is greater than 2.5 millimeters, which is 0.25 millivolts. Things are slightly different in left atrial enlargement. Here is the normal contribution to the P wave from a normal-sized right atrium. And now here's the contribution from the more massive left atrium. Since left atrial depolarization initiates later to begin with, the P wave ends up being overall prolonged. The typical cutoff is greater than 120 milliseconds. You will also note that the P wave in left atrial enlargement may have two distinct peaks, the first from the right atrial depolarization and the second from left atrial depolarization. Another effect of atrial enlargement on the EKG can be appreciated in the precordial leads, specifically lead V1. Here is the heart lying in the chest as seen in axial cross-section. The sinus or SA node, for sinoatrial, is located approximately here. Strictly speaking, the sinus node lies superior to this particular plane. However, this graphic is obviously just an approximation of the anatomy. Here are the precordial leads V1 through V6. What does the P wave normally look like in V1? Remember that right atrial depolarization occurs first, which is directed towards the V1 lead. Therefore, the initial deflection in V1 is positive. Next, left atrial depolarization occurs in a direction away from V1, and thus the second deflection is negative. This convenient separation of the right and left atrial components makes V1 another great lead to interpret atrial activity. In right atrial enlargement, there is greater depolarization towards V1, while the depolarization away from V1 is unchanged. Therefore, the initial positive deflection is unusually prominent. One cutoff used in the literature for the unusual prominence is a height of 1.5 millimeters. However, a much more commonly employed cutoff in practice is an area under the curve of greater than one small box, which is technically 4 millivolts milliseconds. In left atrial enlargement, the opposite occurs. The initial positive deflection towards V1, which represents right atrial depolarization, is normal, while there is an unusually prominent negative terminal deflection. Analogous to previous, the cutoff for pathology is an area under the curve of greater than one small box. This chart summarizes the EKG findings of atrial enlargement. For right atrial enlargement, the P wave in lead 2 can be taller than 2.5 millimeters. The initial positive deflection in V1 can enclose an area greater than one small box, and the P wave axis can be shifted rightward of 75 degrees. For left atrial enlargement, the P wave in lead 2 can be longer than 120 milliseconds and double peaked. In V1, the terminal negative deflection can be greater than one small box, and the P wave axis can be shifted leftward of positive 30 degrees. Here is example 1. This is an example of right atrial enlargement, as might be seen in tricuspid valve disease. The key feature making the diagnosis is in lead 2, which I will enlarge. Remember that an abnormally tall P wave in lead 2 suggests right atrial enlargement. In this case, the P wave height exceeds the 2.5 mm cutoff that is typically used and cited. Here's the next example. This is left atrial enlargement. Once again, we'll zoom in on lead 2. Although the amplitude of the P wave is low, the duration is just over 120 milliseconds, and it has a very distinctive double peak indicative of left atrial enlargement. And finally, here's the last example. This is biatrial enlargement. In lead 2, we see an unusually tall P wave indicative of right atrial enlargement. And in V1, we see a prominent negative terminal deflection in the P wave, indicative of left atrial enlargement. There are a number of other findings here that we have briefly mentioned along the way during the lecture. For example, the QRS axis is borderline rightward shifted, being around positive 90. The QRS voltage is relatively low, and there is poor R wave progression, with the QRS complex in V6 having an S wave that is as deep as the R wave is tall. Overall, while it doesn't strictly diagnose RVH, the constellation of all these findings still suggests this patient suffers from COPD.
Hope you liked our video. Share this information with your loved ones. And don't forget to subscribe to our channel. Thank you.